We'd like to introduce the next speaker, Poemen from Hong Kong, China, who's going to talk about the ocular hypertension treatment study and update and the future.
Thank you very much. It's an honor to be here today. And so I would try to get through this quickly because there are actually quite a lot to get through. These are my financial disclosure. Now, basically, I will give you a brief outlines and backgrounds about what happens in the OAK studies. Cost-effective analysis, quality of life, risk factors, calculations of the risk, and also visual field and the roles of imaging. Now, this is basically the OAKS in a nutshell. So it's a massive cohort with 20 years of follow-up. So in the first 5 years, it was a randomized control trial, treatment or no treatment. And it shows that after treatment, obviously you reduce the rate of having glaucoma by half. And they also identify important risk factors that was combined with the European glaucoma prevention studies, including the older age, high intraocular pressure, thin central corneal thickness, a large photocup ratio, and also high pattern standard deviation value, which I'm sure are quite familiar to most people here. Now, at 7.5 years, they start treating the patients without treatment, right? So everyone is treated, and it shows in the OAKS-2 and 13 years time of follow-up, it shows that the delayed treatment, effectively is delayed treatment, did not actually initiate the process of irreversible deteriorations in most patients, nor it render them to be less responsive to treatment. So you can delay it, you can observe the patient if you have to, and then you have the choice of treating or not treating the patients. And overall, 70% of the patients were treated in the 20 years time frame. And recently, they published the data and showed that the cumulative incidence of visual field loss in at least one eye is about 25%. So the rate is still quite low. All right, I have tried to summarize everything in the Asia Pacific Glaucoma Guideline. You can go and read it up. In the guideline, I've also include the risk factors that is probably going to be related to OAKS. Some of them are related to OAKS studies. Some of them are from other studies. Importantly, the OCT parameters are actually from patients' studies that involve glaucoma suspect. And so thin baseline RNFL perhaps indicates pre-parametric glaucoma and also abnormal classification of RNFL as well. So these are something that you might have to bear in mind. Now, there are certain key issues in ocular hypertension treatment studies, including it shows that it is not cost-effective to treat all patients with ocular hypertension, all right? There's a problem with risk assessments. Also, it's quite difficult to predict who will develop POAG, all right? And also visual field changes and the follow-up schedule is also an issue. How do we monitor these patients? And would imaging actually help us? Imaging is developing a lot, and back in the OAKS studies days, they don't really do much OCT. In fact, it wasn't such a fashion at the time. Now, if you look at cost-effective analysis show, definitely it's not cost-effective to treat everyone, all right? And if you look at the rate of glaucoma development carefully, in fact, to prevent one patient to develop glaucoma in 5 years' time, you're talking about a number needed to treat about 20. So it's actually not very cost effective. And we have to balance between quality of life and also prevention of glaucoma progressions, all right? We know that the drops would actually reduce the quality of life quite a bit for our patients, especially in the long term. And there's no general standard guideline showing telling us what to do. But then, generally speaking, there are many suggestions, and most of them would tell you that you can observe the low-risk group, but be very, very careful about the high-risk group. And importantly, for the pre-parametric POAG in the cohort, they realized that it did not report a lower quality of life. So, functionally, they're fine. And if you think about it, if you have drops for those patients who didn't even have pre-parametric glaucoma, but those with normal patients who might be embedded within the cohort, then you might be causing trouble. Ideally, you only want to treat the patients who will develop glaucoma, all right, and identify the faster progressor and treat them aggressively. You try to avoid medication side effect and also avoid redundant treatment, which is very difficult. This is something you don't want to give for your patient who doesn't really need the drops. In fact, for severe side effect of glaucoma medication, you're talking about a reduction of 10 decibel in mean deviation. So for patients who doesn't really need the drops, you're reducing the quality of life for that patient. And remember, patient with ocular hypertension with no visual field defect, they have perfect health utility. And so reducing them by 10% with the eye drop side effect, it might not be totally justified. You can estimate the risk with the risk scores as shown here. It includes the age, central cornea thickness, intraocular pressure, PSD value, and also the vertical this ratio. All right, so you can assess that. It give you a specific percentage of risk of having glaucoma in 5 years' time. Recently, the polygenic risk score is also getting very heated, very hot. PRS is already shown to enhance the predictive models in macular degeneration, diabetic retinopathy, and also POAG. Perhaps in the ocular hypertension patients, a high PRS has been shown to suggest a higher risk, independent risk factors for POAG development. All right, so this is something we might have to explore, but it's not commonly available in the clinic at the moment. Now, talk about visual field progressions. Most patients would have a slow progression rate in the cohort. However, if you look at it carefully, some of them get really sort of fast progressor, and they get worse despite being followed up in the clinical studies. You're talking about a 6-monthly follow-up, intensive follow-up for the last 20 years. So this is, and they still progress. All right, and the OAK study group suggests that the low risk group, you can monitor them every 12 months, and for the moderate to high risk group, you can monitor them for about every 6 months. All right. Study also shows certain risk factors for the fast progressor. They are some of the familiar risk factors you are probably quite familiar with, and they overlap with the normal tension glaucoma risk factors, in fact. Talk about the visual field pattern. We always have the assumption that the visual field progression start from the periphery, and now we know that they can start early in the central vision. In fact, it could up to 40% of the patients might have central visual loss in the very early stage of glaucoma development. So be very careful about that. The machine learning method might be able to allow us to predict who will develop early glaucoma or become a rapid progressor. But this is something that, again, is not universally available in the clinic. In reality, we have a busy clinic. We might just give that patient's eye drops quite freely without asking about the side effect. In fact, many years ago, I tried to take off the medication for some of my patients. Out of the 107 eyes we deal with, only one patient had repeated visual field defect. And this is the patient. You can see that's an early defect, very subtle. In fact, this patient, even after taking off the medications, he turns out to be a patient with normal tension glaucoma instead of ocular hypertension, which was previously diagnosed. And we managed to stop a lot of medication, so that's a lot of cost saving. But be very careful when you're using the risk estimator, all right? You're making assumption that these are the most accurate variables that you can get from baseline, which is not really quite the case. And so measurement change, their variability, and so be very careful when you're using the risk estimator as a guideline for your treatment. In fact, if you change the vertical this ratio, we try to do that with different measurements, including stereoscopic photograph, HRT, and OCT measurement, and we know they have disagreements, and that disagreement would actually tick all the way to your risk assessment as well. So don't get misled by the score. And it might not be universally applicable to all populations. So it's largely in UK shows that it doesn't really quite work very well in that population. We have to, but the overall re-estimated model was actually performed better. So you need some modification for the risk calculator. Even though it shows this good discrimination treatment for the treated group of the OAK studies. All right. And remember, in the OAK study, the minimum amount of Asians, I remember it was about 20 to 30 Asians. So, whether or not it really works for the Asian, we don't really quite know. Talking about taking off medication, I've been taking off medication for some of the low to moderate risk patients for 5 years. 4 eyes develop glaucoma, so that's quite a low rate. And in fact, imaging could play a role because if you look at these patients, all right, early signs already shown that there are some glaucoma, but it's not really quite in the definitions of the OAK studies. And so the trend-based, the GPA of the OCT already shows early changes followed by visual field defect. And PSD value was the only risk factors that would predict the progressions. Now we have trend-based analysis, which has been shown to be even better than GPA. We have the ROTA, which might allow us to have early detections of glaucoma. In fact, from the ocular hypertension cohort in our studies, 10% of the patients actually have found some early changes, despite the fact that they were judged to be normal. All right. Artificial intelligence, we're still quite early, but there are lots of potential in terms of diagnosis and also predicting who would get a faster progressor or detecting early POAG. Take-home message is that not everyone needs to be treated. We have to balance between quality of life and also preventing glaucoma. It's not as risky as you think, all right? So you might think about taking off some of the medication for some of the patients, unnecessary eye drops if they suffer from side effect. Role of AI is still unknown, but is promising. So I hope that we see you again in the APO next year in Hong Kong, and thank you very much.
Thank you. Any questions from the audience? So, Poemen, if I could ask, has the OHTS changed your practice? So how do you decide if you have a patient in front of you? Not all of us have access to this kind of program you said in terms of determining who to treat or who not to treat, and definitely none of us use AI in clinic. So how do you decide who to treat with eye drops? How often do you follow up in the virtual clinic or doctor's clinic? How do you decide?
It's difficult. I think it's always important. It's the cliche. You know, you discuss with your patients. All right, you tell them that this is perhaps the risk. This is the figures. And you know, right now with these calculations, this is what they tell you. But you know, be careful. This is only for reference. So, do you want to be treated or not? And in fact, some patients who are worried but don't really quite want to do eye drops for their whole life, they might even think about SLT. And you know, in the LIGHT trial, there are a significant number of ocular hypertension patients there. So that might be one thing that you might think about doing. But you know, it's still a bit controversial. So you know, you have to give the option to your patients before deciding what to do. But importantly, monitor your patient.
You have answered that partly, but I just want to know, in high-risk ocular hypertensive, is SLT your first choice beside or the drops, which usually you choose?
Sorry, can you repeat the question again, please?
In your high-risk ocular hypertensives, would SLT be your first choice or the drops? And any trials done comparing SLT head-to-head on medicines on these patients' ocular hypertension?
You mean for the high-risk patients?
Or otherwise, ocular hypertension whom you wish to treat, either would you prefer a SLT or the drop as a first line?
Right, would I prefer doing Zen or the drops? Would I prefer doing the drops or
The selective
SLT or the drop? For the high-risk one, you know, given that they don't really have glaucoma, I might go for SLT, provided that the OCT imaging is very clean. All right, if there's obviously no signs suggestive of preparametric glaucoma, then I might go for SLT. In fact, even if there are, without a significant visual field defect, well, ocular hypertension, no visual field defects, I might still go for SLT. And the thing is, we also have to look at other factors. How high is the pressure? How often is the patient coming back? I mean, there are patients who you do SLT and they just run away, thinking that everything is sorted. All right, so I think it's very dynamic in terms of the decision.
Thank you. I think people are moving towards earlier SLT because of the LIGHT trial data, yeah, especially for OHTs.
Just one more question. If you had somebody was progressing on OCT, but the visual field was still clear, would you then prefer SLT or medication?
Yeah, good question. I'm not sure really, because remember in the OCT, even with the trend-based or the GPA, which GPA is more common, it's not commercially available. Now, even with the GPA, it's telling you that it's a significant, statistically significant RNFL progressive thinning. Whether or not that would translate to a clinical significance, we don't know. We just know that it's a risk factor that would predict visual field progression, but we are not sure whether but you know, in some of the studies that's shown by Chris Leung, they don't all develop visual field defect. So, you know, whether or not we should be doing the treatment decision guided by the OCT, this is quite questionable. For me, I'm not entirely a fan of the light trial. I mean, it's a great studies, but we also have to be very, very aware of that the light trial has a very intensive monitoring system. It's so intensive that it's impossible to be done in the clinic, all right? And also they adjust the intraocular pressure target in terms of what they found in that intensive monitoring. So we have to be practical as well in terms of how reliant we are on the light trial results. It's a great study, but it's very difficult to follow in the clinic.
Okay, thank you very much.